Okay, good evening students. So please confirm if the audio video everything is fine. Please let me know in the comments audio video everything is fine, then we will proceed further. Shall we start? Okay, very good. So now all of you, NEET 2025 is done. All right, we are here for the oral and maxillofacial surgery recall session today. Okay, if you feel that certain options, if you feel that there was something else which was asked, if you feel that some options need to be reframed or the question needs to be reframed, you can please let me know in the comments. Since this is a continuous process of us updating the questions and the options, so we would like to, by the end of this month, like to compile the full authentic recall. So if you feel that there is some alteration or some change that needs to be done to the questions or to the options, you can let me know in the comments there. All right, so I would like to say your exam has been done. All right, and good evening Nikesh. So whatever has been done has been done. We have INI coming up on the 17th. So I would request all of you to focus over there. If you've made mistakes in your exam, if you've gotten questions wrong, it's okay. That has happened. That has passed by. You now need to concentrate on the next step. All right. So the next step is INI. The preparation remains the same. The subjects, the course, syllabus, everything remains the same. All right, and you all have prepared well. So all now you need to go do is quickly do a go through or a revision for your INI. All right, now the questions that I'm recalling we will be discussing. All right, so if I have to do the analysis for the oral and maxillofacial surgery paper, it was the oral and maxillofacial surgery part was, I would say, almost all the questions were either you could find the answers from the notes, or I had taken previous many MCQ based discussions, or your revision series or your predictor series. So the components from these aspects of our sessions you will find in the questions. Yes, there were 2-3 difficult questions which would have been obviously difficult for everyone. All right, not for one or not for just 2-3 students, but for everyone. All right, so let us start discussing the questions one by one. All right, so now students, what I've done is I have segregated the questions topic wise and I have arranged them topic wise. All right, so first of all we'll start from questions of LA, then we'll go to exodontia and so on so forth. So I've segregated or rearranged the questions topic wise. All right, so the first question that we have on screen is Vazirani echinosis nerve block is given for which of the following indications? Option A is treatment of bilateral mandibular anteriors. Option B is treatment of patients who cannot open more than 4 mm, who cannot, or the mouth opening is not more than 4 mm. Treatment in case of failed inferior alveolar nerve block. And D, treatment of multiple teeth in same quadrant. So this was relatively an easier question, I would say quite a direct question. And if you go back to my notes that I have provided during my classes, I had said the main indication for Vazirani echinosis nerve block technique is trismus. Trismus, that is reduced mouth opening. All right, so here option B, treatment of patients who cannot open more than 4 mm or the mouth opening is less than 4 mm. This would be the answer. Alright, so here we had done this. This question you can find the answer to from our notes. Alright, now question 2, the effect of lignocaine toxicity on CNS can be described as, option A is CNS depression only, B is initial CNS depression followed by stimulation or excitation, C is initial excitation followed by CNS depression, and D is CNS excitation only. Alright, so again, if you remember, I had told you 2-3 days before the exam also, we are expecting one question from LA toxicity. Alright, I had told this in the YouTube session just 2-3 days before the exam, where we faculty had come together and we had told you. So I told you one question please to expect from LA toxicity. So again, this is a direct question done many times previously in our sessions again and again. So I would say this is the answer here is initial excitation followed by CNS depression. Okay. All right. Now coming to question number 3, it says which of the following is used as a dilating instrument in forceps extraction. Option A is alveolar bone, B is tooth, C is beaks of forceps, and D is handle of forceps. So this question is a tricky question. It is not a straightforward question. They are trying to confuse you by saying dilating instrument in forceps extraction. Okay. All right. Now I would like to explain with the help of a small diagram. Okay. Suppose if this is the tooth in question and we are supposed to remove this particular tooth. All right. Now coming to option number 1, alveolar bone. The alveolar bone cannot be used for dilatation. In fact, we are dilating the alveolar bone. All right, we are dilating the alveolar bone. All right, so option A is not the answer. All right, now coming to your beaks of forceps. All right, now let us, for example, if this is our beaks of forceps, all right, if this is our forceps, now please understand the beaks of forceps are used to, apply apical pressure, and then subsequently if it is rotational or buccolingual, all right, so subsequently the beaks of the forceps are helping you to deliver the forces to the tooth. All right, now coming to the handle of the forceps. All right, now again, your handle of the forceps, if you remember principles of elevators and forceps where we have done, the handle is your effective arm. All right, this is your effective arm. All right, so because there is a certain amount of movement at the effective arm, there is movement at the resistance or the tooth end. All right, so these are basically, when the forceps come into play, they are basically working on your principles of elevators or forceps to deliver the tooth. Now when you are making certain movements while with the help of the forceps while doing the extraction to deliver the tooth in outside the socket. So in case if you're moving in this direction, all right, so if you would have seen clinically also, when you are doing your extraction, what do your seniors and teachers always tell you? Always hold the tooth, hold the tooth towards its base, towards its apex. Either if it is for the maxillary arch, you hold it there, all right, you place one thumb buccally and one palatally, and if it is a mandibular tooth that you're extracting, you again hold the alveolar bone, all right, one finger goes lingually and the thumb is buccally, all right. So when you are holding it there and when you are delivering forces through the forceps, you will always feel the roots moving, all right. If you have always while doing your extractions, you must have experienced this. You can very nicely feel the roots moving or the tooth getting luxated, all right. So actually what is happening, the tooth is moving in the socket, dilating the socket and facilitating its delivery, all right. So this question was a little tricky one, all right. Tooth is your answer, okay, all right. I hope this question is clear. Now coming on to our next question. A 10-year-old girl comes with painless bluish swelling on floor of mouth. Clinical examination revealed a mucus extravasation cyst in relation to sublingual gland. What would be the correct statement? All right. So the options are sclerosant, B, removal of gland, C, incision and drainage, and D, antibiotics. Okay. So again, this is a question whose answer you will find in the notes. Okay. The ideal treatment here would be excision plus removal of associated or offending gland. Okay, so the best possible answer here would be removal of the gland, all right. This would be the best possible answer. Now coming to question number 5. A radiographically diagnosed chronic oroantral fistula presents with nasal pus discharge. Okay, so this information is important. Which of these would be the appropriate treatment for the patient? Okay, so option A says acrylic plate, antibiotics, and expect spontaneous closure. B is titanium mesh, buccal flap, and buccal fat pad closure. C is antibiotics, excision of lining, and closure with local flap. And D is pus culture, sinus lavage, empirical antibiotics, and spontaneous closure. So I remember this is a previous year question. However, it has not been asked in the exact same way. It has been twisted, or its language has been changed a little. So it's a modified PYQ. All right, it's a modified PYQ. But I also remember when I was taking one of my MCQ based sessions, I think in January or February, I have put this particular PYQ in my session and I had discussed that particular question. Okay, now let us discuss the options one by one and then we'll come to our answer. So the first option says acrylic plate, antibiotics, and expect spontaneous closure. So the part in option A, antibiotics, yes, that is correct. But acrylic plate, why would be given acrylic plate? There is pus discharge. We need to address that. acrylic plate is not going to be of any help. In fact, it's only going to make things worse. So this is not the answer. All right. Option B is titanium mesh, buccal flap and buccal fat pad closure. So buccal flap and buccal fat pad closure part is correct, but titanium mesh, no, we do not use a titanium mesh for oroantral communication or fistula. All right. So again, this is also wrong. Now coming to option C and D. Okay, so option C says antibiotics, excision of lining and closure with local flap. Okay, yes, this can be considered, but now please remember there is pus discharge present. Okay, so option D says pus culture, sinus lavage, empirical antibiotics and spontaneous closure. So if there is pus discharge present anywhere, all right, whether it's from a fistula, whether it's from a unhealed fracture, whether it's from a malunited bone, all right, or it is a draining sinus, okay, wherever there is pus discharge present, the first thing you do is send the pus for culture. All right, after you send the pus for culture, you thoroughly wash and debride that area. All right, that is sinus lavage. And empirical antibiotics, till the time you get culture sensitivity, you give broad spectrum antibiotics to the patient. All right, you start the patients on broad spectrum antibiotics, and then once your culture sensitivity is available, you can change according to what is present in your report. And spontaneous closure. All right, so here I would say if it is a fistula, spontaneous closure, the chances are less. All right, but however, since the maximum of the things in this particular option are the appropriate things to do in such a scenario, this would be the correct answer, option D. Okay, so this would be the correct answer here in this particular scenario. Okay, amongst all the given 4 options, option D is the correct answer. Now coming to question number 6, a patient presents with painful limitation in mouth opening. Okay, so important information, painful limitation in mouth opening. Okay, with no prior history of clicking or popping. MRI of TMJ reveals disc in correct position in closed mouth view, and there is no change in position on attempted opening. All right, so yes, there is difficulty in mouth opening. All right, there is pain on mouth opening. Okay, there is no history of clicking, popping or any sound coming from the TMJ. All right, and an MRI of the joint reveals that the disc is in its normal position. All right, and there is no change of the disc on attempted opening. All right, so the disc, if the disc is present in its normal anatomic position, then there is no internal derangement of TMJ. All right, this is not a case of internal derangement. Okay, difficulty and pain in mouth opening, it can be due to MPDS. All right, so what is happening if there is spasm of the masticatory muscles? Your disc is not going to be displaced, it is going to be normal anatomically. All right, yes, the patient may have difficulty in mouth opening, pain in mouth opening or tenderness in the areas of muscles of mastication. So for such, let us see our options now. Arthrocentesis is ruled out because everything is normal within the joint. Again, arthroscopic surgery you do not need to do because there is no pathology within the joint. All right, And discoplasty also we will not do, because the disc is normal and there is no pathology affecting the disc. So the best that we would advise the patient is to limit mouth openings, soft diet, and give some NSAIDs and anti-inflammatory drugs. That is your first line of treatment. So option C would be the correct answer. Okay. Now coming to question number 7. In Champy's superior border mini plate fixation of angle fractures of mandible, which of this is correct? Okay, so option A is it can injure the lingual nerve. No, this is incorrect. It does not injure the lingual nerve. It can act as a compression band. No, Champy's plates are non-compression osteosynthesis. Alright, they are non-compression osteosynthesis. It can resist torsional forces in combination fractures. This is also not correct. Option D is it can provide functionally stable fixation. This is absolutely correct. Alright, and we have mentioned in my notes also during the classes that based on rigidity of fixation, Champy's plates provide semi-rigid or functionally stable fixation. Alright, fine. Let us move on to the next question. A patient is brought to emergency room after RTA in intoxicated condition, uncooperative, and does not elicit any cervical spine tenderness. Okay, what steps should we take for prevention of C-spine injury? Now there's history of RTA. Patient is intoxicated. He is uncooperative. Alright, that means the patient is not obeying your commands, is not cooperating in his inspection and palpation and his treatment and his examination. He does not elicit any cervical spine tenderness. That means there is no tenderness in the cervical spine region. What steps should be taken for prevention of C-spine injury? Alright, so now option A is reassessment, B is CT cervical spine, C is MRI cervical spine, and D is cervical collar application. Okay, now CT cervical spine and MRI cervical spine are not the answers. Alright, these are done to rule out a cervical spine injury but not prevent them. Alright, the question is asking prevention. What will you do for prevention? Now the confusion remains between option A and option D. Some people might get confused thinking that there is no cervical spine tenderness, so we might reassess the patient. No, you will not reassess the patient and waste time. You will apply a rigid collar, a cervical collar to the patient. Alright, so this is your answer. And if you go back to my class notes, I have given the sequence also for cervical spine stabilization. So purposefully built head immobilizers, I had given this sequence in my class also, followed by board and bindings, followed by rigid collar. Alright, this is a sequence present in our notes that we use these things for stabilizing or preventing injury to the cervical spine if we suspect a cervical spine injury. Alright, now coming to question number 9. This was again a twisted question, although I have in my predictor series I have done intubation. I had revised intubation with all of you. Okay, so again this is a little twisted question. It says a facial gunshot injury patient with expanding hematoma presents to you. What should be the immediate next step. All right. Now, first of all, I want you all to understand there's a facial gunshot and there's an expanding hematoma. So when there is a gunshot, all right, it most of the time results in a burst kind of an injury. All right, it results in a burst kind of an injury. Now, depending on the type of the bullet, depending on the range from which the bullet has been fired, and depending on the velocity. So there are a lot of things that come into play in a facial gunshot injury. All right, now most of the times a gunshot injury will result in a burst kind of a injury. All right, so when I say burst kind of an injury, that means that the anatomy might be distorted. All right, the general anatomy of your facial skeleton might be distorted. One. Second, the question says an expanding hematoma. All right, so an expanding hematoma of the orofacial region will quickly lead to an airway compromise. It will lead to quick deterioration of your airway. So the first thing here that you have to do is secure the airway. All right, now that is what exactly the question is asking. How are you going to secure the airway in such an emergency kind of a condition? You will not do a CT scan for sure. You will not do a surgical exploration for sure. You have to secure the airway. Now the confusion remains between nasotracheal intubation and cricothyroidotomy. All right, so I just now told you that the anatomy might be distorted and there is an expanding hematoma along with that, so you have to be very quick and you have to immediately secure the airway. Now, nasotracheal intubation, why should not be the preferred choice is because one, the anatomy is distorted, and second, a nasotracheal intubation takes or is more time consuming than an oral intubation. But here we do not have oral intubation in the answer, in the options. Even if we would have had oral intubation in the answer, it is again questionable because of the distortion of the anatomy or the distortion of the facial skeleton or facial region. All right, the best would be to secure an airway here. All right, so cricothyroidotomy is your best answer over here. That although it is a emergency airway, it is a short time buying airway, it is not a definitive airway, but for immediate securing, for your immediate needs of securing the airway, you can use a cricothyroidotomy immediately and then decide further after securing the airway what is the definite airway that we can introduce. All right, coming to the next question. A patient presents with severe submandibular swelling, trismus and raised floor of the mouth. CT reveals severe cellulitis with flecks of pus. What would be the immediate next treatment in management? So there is a severe submandibular swelling. That means large submandibular gland swelling with trismus and raised floor of mouth. Right? So your raised floor of mouth indicates a airway compromise. All right, and CT reveals severe cellulitis with flecks of pus. That means there is pus that is collecting. All right, what would be the immediate next step in management? So if you all remember, I had taken a similar question in my predictor series. All right, where I had told you there are two things for a Ludwig's angina patient. One is the first step in treatment, and second is what is the definitive treatment or the choice of treatment or management of a Ludwig's angina patient. So I told you if they ask you the first step, you will always secure the airway. that is do your tracheostomy. And if they ask you what is the treatment that you will do or how you will manage this patient, then the answer would be incision and drainage. All right, so here amongst the given options, incision and drainage, this is not what you do immediately. This is after you stabilize the patient. IV clindamycin is not something that you do immediately. Once you secure the patient, stabilize the patient, and then maybe you start on antibiotics, but definitely not clindamycin. Pus culture also, once you have established a drainage, stabilize the patient after that, but the immediate step that you do is tracheostomy. You secure the airway first and then proceed with whatever you want to do. Okay, all right, so option D is the correct answer over here. So question 11, a patient needs tooth extraction in a previously irradiated area. Which of this is the biggest concern in this patient? This is again a very straightforward question. All right, the answer here would be osteoradionecrosis amongst the given options. And I had taken a YouTube session on osteoradionecrosis and osteomyelitis, if you all remember. So if you have gone through that session of mine, this would have, you would have been able to answer this easily. All right, now again, question number 12, a child with cleft lip and palate comes to you. What would be the correct timing of cleft palate surgery considering an optimal speech development? All right, this is a previous year's questions and has also been discussed by me on YouTube MCQ based session. All right, so the timing for cleft palate surgery is 9 to 18 months. All right, it is 9 to 18 months. Okay, is it clear? Coming to question number 13, which of the following is correct regarding the use of CPAP, that is continuous positive airway pressure in case of OSA, that is obstructive sleep apnea? Now, this is a difficult question. All right, let us go through the options first and then I'll tell you my answer. Option A is CPAP causes increase in air pressure of throat during sleep. B is CPAP prevents collapse of patient's airway during sleep only when used with an oral appliance. C, CPAP is primarily indicated in case of OSA needing invasive treatment. D, CPAP is not an effective modality in cases of severe obstructive sleep apnea. So this was a difficult question, and CPAP is something which is basically, it comes more under respiratory medicine than per se with oral surgery. All right, so whenever a patient requires CPAP, it is usually the settings of CPAP are told to you by a respiratory medicine specialist. Now CPAP is basically a non-invasive ventilation sort of a thing. So what do we have for a CPAP? We have a small machine, all right, which maintains positive pressure ventilation throughout your airway. All right, so there are certain settings in the CPAP depending on the severity of your obstructive sleep apnea. A particular pressure setting is entered into the device and it continuously delivers that pressure down the upper respiratory tract so as to keep the respiratory tract patent. All right, now, so we'll keep CPAP aside for a minute and we'll see obstructive sleep apnea. Now, obstructive sleep apnea can be due to a lot of things. All right. It can be due to micrognathia, retrognathia. Obstructive sleep apnea might be due to severe obesity. All right. Obstructive sleep apnea might be due to anatomic variations of the upper airway structures. So these are the reasons for obstructive sleep apnea, even ankylosis. All right. Now, especially when obstructive sleep apnea is due to obesity, or it is due to altered altered anatomy of the upper airway tract, in such cases we assess the severity of obstructive sleep apnea. And whenever there is a patient of obstructive sleep apnea, before prescribing any invasive treatment modality to the patient, the first line of treatment is always CPAP. All right, it is always CPAP. So I collected a little information regarding CPAP from various sources, from different books and from different articles. All right, so I would like to highlight here a few points. It is a type of positive airway pressure where the airflow is introduced into the airways to maintain a continuous pressure to constantly stent the airway open, or to maintain the patency of the airway in people who are breathing spontaneously. All right, fine. Now there's a textbook of oral and maxillofacial surgery. It says continuous positive airway pressure is usually the first line of treatment of obstructive sleep apnea, and it works on the principle of binding the upper airway in an open position to improve patency during sleep. Okay. So again, CPAP is the first line of treatment for moderate to severe obstructive sleep apnea and may be used occasionally in mild OSA also. All right. Now, there is this article published in Journal of Clinical and Sleep Medicine. It says positive airway pressure is the treatment of choice for mild, moderate and severe OSA and should be offered as an option to all patients. Alternative therapies may be offered depending on severity of OSA and patient's anatomy, risk factors and preference should be discussed with the patient. All right. Now there is another article in Therapeutic Advances in Chronic Diseases. All right. It says that CPAP is generally administered through the nose. All right. And it is constantly recommended as the first choice of treatment in patients with moderate to severe obstructive sleep apnea. All right. So now let's get back to our options. We'll start from option D first. CPAP is not an effective modality in cases of severe obstructive sleep apnea. This is wrong. It is not that it is not always ineffective. In some people with obstructive sleep apnea, with severe obstructive sleep apnea, CPAP is beneficial, and in some people it is not. All right. And CPAP, coming to option C, CPAP is primarily indicated in cases of OSA needing invasive treatment. No. Invasive treatment, if the patient needs invasive treatment, then we do not go for CPAP. All right. Coming to option B, CPAP prevents collapse of patient's airways during sleep only when used with an oral appliance. No, this is also incorrect. So basically your CPAP can be used, it can be used in three ways. It can be used via nasal prongs. All right. It can be used along with an oral device, and it can be used along with a mask. All right. So this part, it can be used only when with an oral appliance. This is wrong. And option A says CPAP causes increase in air pressure of throat during sleep. Yes, I told you that it causes increase in, so there is a particular setting of CPAP. It delivers a set amount of pressure down the upper respiratory tract to maintain its patency. Alright, so option A, CPAP causes increase in air pressure of throat during sleep. This is what I think should be the answer over here. Alright, after going through many things in literature, I personally feel option A should be the best answer over here. Okay, now coming to the last question of our discussion. Okay, a patient with mandibular angle fracture comes with infection. Which of this bacteria is responsible for fracture infection? Alright, now again this was a little twisted question. They basically wanted to ask you the organism responsible for an oral infection. Alright, they wanted to basically ask you the organism, the causative organism behind an oral infection. So the most common organism that is found in orofacial infections is your Staph aureus. Alright, this majority of the infections, or this is the most common organism. Yes, aureus, Staph aureus. Alright, Florence, it was asking you regarding the most common organism that is responsible for orofacial infections. That is nothing but your Staph aureus. Alright, with this we end our discussion. Alright, so I hope you have got maximum of your questions right. Even if not, please don't lose heart. Alright, we have INI-CET coming up. I want you all to prepare well for that exam. Alright, do well in that exam. Is medical subject recall alright, I'll ask the team to update you regarding the medical subject recall. Alright, Nikesh, fine. So in case you think that any question has been missed out, or you want to ask me any other question that I've missed out in my recall session, you can please put in your query on the WhatsApp group. Alright, and I'll try to answer your question over there. Alright, so do we have any doubts? Even if you think something was not asked, or some language, you even want to do the correction of the language of the questions that I've put out today, you can let me know on the WhatsApp group. We will reframe, we can always reframe our questions. Alright, so thank you students, wishing you all the best for INI-CET. Do well. Thank you.